Dear colleagues, it's my great pleasure to welcome you in this seminar in the series of the Department of Epidemiology of the Harvard School of Public Health. My name is Bert Hoffman. I'm the chair of epidemiology, and it is my great pleasure to also welcome, foremost, I must say, welcome our speaker of today, Dr. Kevin Kensler. Dr. Kensler is currently assistant professor of population health sciences in Weill Cornell Medicine. He came from here, our institution, worked until 2018 in the Department of Epidemiology of the Harvard School of Public Health, later in the Dana-Farber, and is now mainly, I would think, at the Edward Mayer Cancer Center at Weill in New York. It's wonderful to have you, Dr. Kensler. You work on prostate cancer epidemiology, on the various aspects of it, and I will give you the floor to talk about prostate cancer screening, what's gone wrong, and what can we get right. Wonderful to have you. Go ahead.
So thank you for the kind introduction and for the kind invitation to join the seminar series today. It's wonderful to be back at Harvard, even virtually, and see some familiar names and faces on the call today. I've chosen a somewhat provocative title for my talk, What's Gone Wrong, What Can We Get Right with respect to prostate cancer screening. I think we've made a substantial progress over the past 3 decades of prostate cancer screening and trying to optimize some of the benefits and harms, but we still have a long way to go. So hopefully we can think together about what the road forward might look like. So just a little bit in the way of background before we really dive into prostate cancer screening. Prostate cancer itself is the most commonly diagnosed cancer among men in the US, with more than 300,000 cases diagnosed annually. And then there are about 35,000 deaths annually from prostate cancer among men in the US. So incidence is considerably higher than mortality. The majority of men who are diagnosed with prostate cancer will ultimately die from other causes. So one of the key challenges that we face within the prostate cancer space and prostate cancer epidemiology is trying to differentiate between the slow-growing indolent prostate tumors that confer lower risk of significant morbidity or mortality versus the more aggressive ones that ultimately lead to prostate cancer deaths. Another notable feature about prostate cancer is that there are extensive disparities across racial and ethnic groups in the US in terms of incidence and mortality, and these mirror patterns that we see globally. So in particular, Black men have a higher burden of prostate cancer, including higher prostate cancer risk. And prostate cancer incidence among Black men is roughly 3-fold higher than what we see among Asian or Pacific Islander men in the US, who have the lowest risk of being diagnosed with prostate cancer. These gaps are somewhat larger for prostate cancer mortality, with about a 4-fold difference in risk of prostate cancer death comparing non-Hispanic Black to non-Hispanic Asian or Pacific Islander men. So that's important context when thinking about targeting screening towards higher risk populations for whom the benefits to harms ratios might be more favorable. So the plot on the left here shows prostate cancer incidence and mortality rates for Black men and white men in the US from 1975 until 2015. The 2 upper curves are the prostate cancer incidence rates, while the 2 lower curves are the prostate cancer mortality rates. There's a few things worth noting here. One, the disparities that I mentioned on the prior slide have been quite persistent over time. We've made very limited progress in actually closing these gaps in incidence and mortality. The curves you do see have closed a little bit, but there's far more work to be done in that area. And then also notable is that the prostate cancer incidence curves over time have a rather distinctive shape that with a strong peak in the early 1990s. And this coincides with the introduction of prostate cancer screening on a widespread population level using the serum biomarker prostate-specific antigen, or PSA. So we see this rapid spike in prostate cancer incidence in the late 1980s into the early 1990s, and then incidence rates have declined since then. Prostate cancer screening, pretty much since its inception, has been highly controversial in that it hasn't been clear that the benefits of screening, particularly with reducing prostate cancer-specific mortality, outweigh some of the harms that are associated with screening. The U.S. Preventative Services Task Force, USPSTF, is an organization that makes recommendations regarding preventative healthcare procedures and services within the U.S. And roughly for about the first 2 decades that prostate cancer screening using PSA was around, they declined to make a recommendation about its use, citing a need for grade 1 evidence from randomized clinical trials. In roughly 2010, this evidence finally came in the form of 2 large-scale randomized clinical trials, the ELCO trial in the United States and the ERSPC trial in Europe. And collectively, these 2 trials, at least in these initial reports, did not support a mortality benefit associated with prostate cancer screening. As a result, in 2012, the U.S. Preventive Services Task Force issued a grade D recommendation against routine prostate cancer screening, saying that men at average risk, for them, the harms outweighed the potential benefits of screening, and therefore it should not be done on a population scale. We'll dig a little bit more into the benefits and harms and later follow up from these trials in just a minute. But broadly, since the issuance of this 2012 recommendation, we've seen a decline in prostate cancer screening. So this is results from analysis a few years ago that I led with Tim Rebick at Dana-Farber, in which we looked at prostate cancer screening rates over time across racial and ethnic groups in the wake of this 2012 decision. And overall, we saw about a 10% decline in prostate cancer screening rates. A few things worth pointing out here in the figure. Even in 2012, prostate cancer screening rates were quite low, in particular compared to other cancer screening modalities. So this figure shows the proportion of men who self-reported in the behavioral risk factor surveillance system receiving a PSA test in the prior year. When you look at concordance with other cancer screening modalities, such as colorectal cancer screening, breast cancer screening, cervical cancer screening, upwards of 60%, sometimes upwards of 80% of the US population is in concordance with those guidelines. Even at the height of prostate cancer screening, it never reached really about 50% of the US population. So prostate cancer screening was quite low in 2012 to begin with, relative to other cancer screening modalities, and it's declined since then. And of course, we see notable differences across racial and ethnic groups in the US as well. In particular, prostate cancer screening rates lag behind among Hispanic and non-Hispanic Asian or Pacific Islander populations, but there have been declines across the board with respect to prostate cancer screening in the decades since this 2012 recommendation. I don't show the data here, but in particular, among younger non-Hispanic Black men, we saw an even larger drop-off in screening rates, particularly among men ages 40 to 54. So where are we today in terms of the benefits and harms of prostate cancer screening? Well, I think there is pretty good evidence of a benefit these days. So those 2 trials that I mentioned, the PLCO, the ERSPC trial, now have accrued an additional, in some cases, 15 years of follow-up. And the hazard ratios now are about 0.8 to suggest that prostate cancer screening does lead to about a reduction of 20% of prostate cancer deaths and mortality. And we've also reconciled with some of the flaws in the design of these trials. In particular, there was widespread contamination in the PLCO trial in which more than half of the men in the control arm actually got screened for prostate cancer. So it might not be a really strict comparison of prostate cancer screening versus no screening, but rather organized prostate cancer screening versus opportunistic screening. Other evidence can come from more epidemiologic sources, like this is a nice study that was conducted by the CISNET group this past spring. And so the CISNET group does simulation modeling for cancer control interventions, including cancer screening. So you can see the prostate cancer mortality rate is shown in the line in the black there, peaks in around 1990 and has declined through 2020. And using simulation modeling, the CISNET group tried to decompose this decrease to understand the relative contributions of screening to this decrease in mortality versus what is the contribution of advances of treatment. And their overall conclusion was that widespread prostate cancer screening had led to about 54 to 67% of this reduction. So since 2012, I think we've gained a better understanding that prostate cancer screening does actually result in fewer deaths from prostate cancer. That being said, there are still harms that are associated with prostate cancer screening. So these are the harms that were cited within the USPSTF's evidence summary in their 2018 recommendation, their most current recommendation. And as prostate cancer screening is really the first step in the prostate cancer care continuum, we can think of some of the consequences of treatments and diagnostics that come around later in this continuum as potential harms of screening itself as well. So prostate cancer screening using PSA is an imperfect test. There are, of course, false positives and false negatives that occur with this. In the PLCO trial and the ESPC trial, these were estimated to be, 15% or more false positives among the intervention arm participants. And the USPSTF stated that about 30 to 50% of aggressive prostate tumors are missed using PSA-based screening. Should a man have elevated PSA, though, he might proceed to receive a biopsy. The biopsy itself has complications that could arise, including pain, infection, and spermia. And at that time, it was estimated that about 1% of prostate biopsies, the man ended up having to be rehospitalized for some consequence of that biopsy. The biopsy could then lead to a diagnosis, and it's estimated that about 20 to 50% of prostate tumors were overdiagnosed. They might then get treatment for said tumor, most commonly using surgery, radical prostatectomy, or radiation. Radical prostatectomy and radiation have consequences on quality of life in domains like erectile dysfunction, urinary incontinence, and bowel symptoms that can cause long-term deficits. And then finally, there can be psychological harms of this entire process with anxiety, depression, not uncommon among men that have positive PSA screens or subsequent prostate cancer diagnoses. A couple things worth adding here. Generally, the risk of these harms increases with age. Things like overdiagnosis are more likely to occur among older men. And this is sort of the state of the evidence back in 2018. We've continued to make progress in pretty much every one of these domains, such that the rates of harms have gotten considerably better over time. So where do we stand today? Well, the USPSTF still stands by their 2018 recommendation. They're supposed to be updating it right now, but who knows quite what's going on with them at the moment. And their current recommendation is that men ages 55 to 69 should engage in shared decision-making with their provider about prostate cancer screening. So men in a healthcare setting should talk with their healthcare provider about the potential advantages and or disadvantages of prostate cancer screening before deciding whether to proceed with the PSA test. U.S. Preventive Services Task Force also acknowledges that men at higher risk of prostate cancer, including Black men and men with a family history of prostate cancer, might benefit from starting at screening prior to age 55. A couple more contemporary recommendations are from the AUA, as well as the Prostate Cancer Foundation, who released guidelines specifically for Black men. Both of these guidelines emphasize shared decision-making and suggest that men at higher risk, Black men and at a family history, should probably start thinking about screening at age 40 rather than 55. So there's several other organizations out there, national, that provide cancer screening recommendations. Pretty much every recommendation these days emphasizes shared decision-making. There's general agreement across these recommendations that men at higher risk of prostate cancer might benefit from an earlier age of initiation. And then no organization recommends routine screening beyond age 70. And as an addendum to that, many of them recommend that men with less than 10 years of life expectancy should not be routinely screened, as given the long natural history of most prostate cancers, these men are unlikely to benefit. Ultimately, as I'm going to show, I think there's a somewhat limited congruence between these recommendations and what's actually happening in practice. So let's start at sort of the older end of the age continuum here, where, again, no men beyond age 70 are recommended to receive routine prostate cancer screening. So this was an analysis using BRFSS data that our group had last year, in which we looked at prostate cancer screening practices across age and life expectancy groups, particularly among older men. And you can see from the plot on the left, which again shows the frequency of men who self-reported being screened in the prior 2 years, the prostate cancer screening actually peaks outside the recommended age range. The highest screening rates we actually see are among men ages 70 to 74, and screening rates remain quite elevated beyond this age range, men in their late 70s into their 80s and 90s, relative to men that are actually within the guideline recommended age, such that we still see, of men in their 80s or older, roughly 30% of them are still getting reported receiving recent prostate cancer screening. We also applied a life expectancy estimator to understand 10-year risk of mortality that these men were facing based on comorbid conditions and functional status. So you can see within age groups that there is, in fact, an inverse association between predicted 10-year mortality risk and prostate cancer screening rates based on the BRFSS data. But I would argue that the magnitude of this association is really not what you would hope in practice. So if we think about the benefits and harms, generally they're going to get worse with age, they're going to get worse with higher predicted mortality risk. And you can see that the screening rates are pretty comparable among the older men with highest mortality risk to where they are among the younger cohorts with the most favorable health status. So it seems that, particularly when we look at this 80 plus group, there's about 30% of men with greater than 70% mortality risk that continue to get screened, even though in practice, this is a group that has very little likelihood of actually benefiting from screening. So we've been trying to dig a little bit more into what are the factors that actually influence decision-making regarding continuation of screening into the individual's 70s. So this is work that's led by Miles Reed, who's a medical student here at Weill Cornell. And we've been using data from the All of Us research program to try and understand in a cohort of 9,000 men who all received prostate cancer screening in their late 60s, what are the factors that influence whether they continued into their 70s? And in particular here, I'm going to show data based on PSA level at age 70, as well as, again, their life expectancy, their predicted 10-year mortality. And overall, we see that about 70% of them continue screening into their 70s. And the plot on the left, again, breaks this down by PSA level within the colors, and then in 3 different groups based on their 10-year mortality risk. Even among the group with the highest mortality risk, greater than 80% chance of dying from non-prostate cancer causes within the next 10 years, and those with the lowest PSA, so the lowest likelihood of developing prostate cancer, we see that about 60% of them still continue to get screened. In multivariable models, you can see that there are some associations. So higher PSA level is associated with a higher likelihood of continuing screening, rather modest association, and then higher 10-year mortality risk is associated with a lower likelihood of continuing screening, but again, pretty modest in the magnitude of this association. We've also looked at sociodemographic factors in relation to this. None of them seem to really be predicting continuation of screening. And really, in practice, the strongest predictor that we see is the frequency with which you were screened prior to age 70 is the strongest predictor of whether you will continue to screen into your 70s. So it does seem that, for the most part, people are just continuing the cadence that they have without actually tailoring this decision to continue screening based on prostate cancer risk or health status otherwise. So I'm not going to pretend, though, that this is like an easy topic and this is a slam dunk. I think that these screening discontinuation conversations are quite thorny and unpleasant for patients and providers. In aggregate, at a population level, I would say that the majority of men are unlikely to benefit from continued screening but beyond age 70. There may be a subset of men who are in very good health at age 70 that do end up benefiting from continued screening. I think we can think of former President Joe Biden as an example of this. So he, as you might have noticed or heard, this past spring was diagnosed with metastatic prostate cancer. He had actually stopped screening at age 70 per guidelines and then got a metastatic prostate cancer diagnosis at age 82. So he might be someone that would have benefited from continued screening, but I would argue that he's probably more so the exception than the rule. Nancy Schoenberg has done a lot of work sort of examining the nature of these conversations regarding cancer screening discontinuation, and particularly the role of life expectancy is difficult for both patients and providers. Patients generally don't like to hear about life expectancy, and they struggle to understand how life expectancy should be incorporated into cancer screening discontinuation decision-making. And then providers are often wary of using it themselves, citing difficulty in estimating it, as well as communicating it to patients, and also on concerns about, again, the exceptions of the people that might have benefited and withholding this care from people who could potentially benefit, even though most of them will not. So I think that's one issue that we're facing today in the prostate cancer screening landscape. But another issue that we're facing is the rise of distant prostate cancer. So these are data from the SEER program, our National Cancer Registry program in the US from 2004 to 2017. And you can see in 2010, there's an inflection point in the plot on the left, at which point distant prostate cancer incidence started to rise across every single racial and ethnic group. Again, non-Hispanic Black men here are the group in blue, and distant prostate cancer incidence, metastatic prostate cancer incidence is considerably higher for non-Hispanic Black men relative to other racial and ethnic groups within the US. More recent analyses have extended these trends, and this trend of rising distant prostate cancer incidence is continuing. So there's a clear need to improve screening uptake among higher risk populations and underserved communities to particularly try and mitigate some of these metastatic prostate cancer diagnoses. But there's a lot of barriers that exist in practice to doing that. So we've been, again, using data from the All of Us research program to try and understand which barriers to healthcare are most strongly associated with prostate cancer screening. So this is work led by Erin Garaya, who is a urology resident at Weill Cornell. And we've been looking among All of Us participants ages 40 to 74, who at time of cohort enrollment reported whether they had ever delayed receiving healthcare in the past year for any of the following reasons. And they were given the 9 different reasons that you're shown on the left. So that table shows the number who provided an affirmative response to that reason. So the most common reasons were really things related to healthcare insurance or concerns about costs of receiving care. But you can see that things like being nervous about seeing a provider or not having transportation or having difficulty getting time off work were commonly reported barriers to accessing healthcare and cancer screening as well. Using these 9 responses, we created a score ranging from 0 to 9 that was just simply the sum of the affirmative responses that they provided. And the men who reported 3 or more of these, it was about 15% of the cohort, ultimately got screened for prostate cancer at a 37% lower rate compared to men who reported none of these barriers. So these barriers to accessing healthcare are real, they are common, and ultimately lead to decreased screening, and then might be in part responsible for some of the increases in metastatic prostate cancer incidence that we see. So I think this figure actually does a pretty good job of summing up where we've gotten to over the past 10 to 15 years of prostate cancer screening. This was an analysis led by my colleague Mina Davaluri here at Cornell, again, using SEER registry data. And we looked at trends in stage-specific prostate cancer incidence by neighborhood socioeconomic status using the Yost index, which is a composite measure, geospatial measure at a census tract level, incorporating factors like education, income, health, uninsurance rate, so on and so forth. The plot on the left here shows incidence rates of localized prostate cancer incidence across neighborhood socioeconomic status, while the plot on the right shows distant prostate cancer incidence, and you'll see that there's differing trends. So localized prostate cancer incidence is highest in the highest socioeconomic areas. So when we think about things like overscreening, potential overdiagnosis, these potential harms are really concentrated in higher socioeconomic areas, whereas we see an inverse trend between neighborhood socioeconomic status and distant prostate cancer incidence in the plot on the left. So when we think about delays in diagnosis, metastatic disease at time of diagnosis, these harms and subsequent prostate cancer mortality, these harms are really concentrated in lower socioeconomic areas. So overall, where are we? Well, I don't know that this will be the most profound conclusion, but generally I would say that our screening practices are still somewhat misaligned with actual prostate cancer risk. So certainly we have far too little screening in communities where the benefits would be the greatest. These are among younger age cohorts, men at higher risk of prostate cancer, men living in underserved areas. Then we also have too much screening at times when the benefit is low. So men that have reached their 70s seem to have very low risk of prostate cancer based on PSA levels, seem to continue to be screening and incur higher rates of overdiagnosis and perhaps overtreatment and subsequent deficits in quality of life. So I'm doing work in both of these areas, but I'm going to just, for the rest of our time, I'm going to highlight one initiative that I've been contributing to that focuses on this first issue of increasing screening in the areas where it could benefit the most. So I'm at Weill Cornell, as Dr. Hoffman said, which is based in New York City. You can see it's denoted in the red star there. We're on the Upper East Side of Manhattan, but have affiliates in Brooklyn and Queens. And the map on the right shows prostate cancer incidence across neighborhoods within New York City, with the neighborhoods in yellow having higher incidence and the ones in blue having lower incidence. You can see the highest incidence rates of prostate cancer are concentrated in central Brooklyn in neighborhoods like East Flatbush, Brownsville, Oceanville, Crown Heights. And actually, the lowest rates of prostate cancer are just a few miles away in southwestern Brooklyn in the neighborhood of Bensonhurst. So overall, there's about threefold variability in prostate cancer incidence over a geographic span of about 4 miles. But clearly, the burden of prostate cancer is highest in Brooklyn within New York City, and so we've been working to try and ameliorate that burden there. So I with colleagues in the community, as well as at Weill Cornell, have been part of an initiative we've titled Shape Up. So Shape Up has the mission of empowering men in Brooklyn through barbershops to prioritize and advocate for their prostate health through education and screenings. We have been in the past supported by a Department of Defense Prostate Cancer Research Program Healthcare Disparity Research Award. Unfortunately, we received a stop work order for that this past spring and have been in limbo since, but are plotting our ways to continue forward. But the main goal of Shape Up is to improve access to prostate cancer screening through 2 modalities. So the first is actually to develop a point of care PSA test. So traditionally, PSA testing is done in clinical settings through blood draws with your healthcare provider. We are hoping to develop and validate a point of care test that can be used in non-clinical settings. And then to take this test, we plan to implement it in barbershops. So we plan to have the barbers actually talk to their clients about the importance of prostate health. And should their client decide that they want to get screened that day, the point of care test would be available and for use and for screening. So for this, we put together a multidisciplinary team of stakeholders from the scientific and Brooklyn communities. On the Weill Cornell side, this includes people with expertise in urology, primary care, laboratory science, epidemiology, as well as health communication. And then from the community side, we put together stakeholders that are barbers, prostate cancer survivors, community-based primary care physicians, otherwise community leaders. So everyone's bringing their expertise and experience to the table to think about the appropriate study design and implementation of this initiative. So the first step in our project is actually to develop and validate the point of care PSA test. So in practice, this actually is pretty similar to the rapid COVID test that I think all of us are familiar with at this point. So it's a lateral flow test strip. The key difference here would be for a COVID test, you add a solute based on a nasal swab. Here, we're adding blood from a finger stick blood collection. It gets added to this lateral flow test strip. You wait 10 to 15 minutes for it to flow across that test strip. And in this case, you should see 2 lines, a control line and then a test line. And then based on the relative intensity of these 2 lines on the strip, we can use our cube reader to get this T to C ratio that can then be back calculated to give us a quantitative estimate of PSA concentration. So what do these actually look like in practice? It's a nice little cartoon we have there, but here's the actual test strips and readers. You can see the lateral flow test strip there with the 2 lines on the left, our reader in the middle, and then when you stick the reader on top of the lateral flow test strip, it provides a quantitative T to C estimate that we can then use to back calculate the PSA level. So with our point of care PSA test, we've been actually doing 2 clinical validation studies before we take this out into the field. The first one of these actually examines if you take capillary PSA, PSA as measured from the finger stick blood draw, as well as your standard venipuncture blood draw collection and calculate PSA there and run it on the standard laboratory instrument. Do you get the same result? And lo and behold, we got excellent concordance between our capillary PSA from the finger stick and our standard venous PSA that would be standard of care within a clinical setting with a correlation of about 0.99. We've also done a validation study to compare the finger stick point of care test to the standard venipuncture PSA. Here again, we have strong agreement between the 2 measures with a correlation of about 0.88. We did exclude one man from our urology clinic who had a PSA greater than 180, since we're expecting that men within the study would have PSA range in the ranges of 20 and below. If we apply a common threshold of 4 nanograms per milliliter to indicate elevated PSA, we have excellent sensitivity and specificity, albeit perhaps a little room for improvement in terms of specificity. So we're continuing to validate and refine these processes. We also have very good data for test reliability in terms of test retest. But we've done a successful job of putting together this point of care test and validating its use. So the next step for us is actually to take this out into the community and work with the barbers to implement prostate cancer screening within their barbershops. For this initiative, we're using a citizen scientist model. So citizen scientists are community champions with strong neighborhood ties who are motivated to promote neighborhood health and wellness. And they can act as a link between the research team and the community to promote health and participation in medical research. And with the context of ShapeUp, we are hoping that the barbers will promote particularly prostate health by encouraging screening and community participation within the initiative. So to prepare the barbers to actually talk about prostate health and prostate cancer screening, we've been developing a training program for them that's comprised of 5 different modules that they will take over the course of 5 weeks in the lead up to launching the initiative. So these are each going to be in-person modules that are probably going to be about 60 to 90 minutes in length, in which the barbers will meet with a variety of different members from our study team, both community members and scientific faculty members, to sort of talk about different elements of the ShapeUp initiative. So Module 1 introduces ShapeUp and has the barbers create a team mission statement. Module 2 really focuses on the nitty-gritty of prostate health. So they learn a little bit about prostate anatomy and physiology, conditions that affect the prostate cancer screening. Module 3 will then focus on engaging their social networks, thinking about how they can use their own personal narratives and motivations to help communicate the importance of prostate health and taking actions for one's health to potential clients, as well as techniques within motivational interviewing. Module 4 then focuses on research ethics. There's pretty extensive mistrust of biomedical research studies in the community. So this is intended to provide greater context in sort of how our medical research studies actually approved, what are the ethical safeguards in place, and in particularly how are these been applied to the design and conduct of ShapeUp. And then the final module is just going to focus on the details of how is this study going to actually work in progress. They'll get to see the point of care PSA tests in action and engage in mock conversations to try and anticipate some issues that might arise in the implementation. So as I said, we are still under a stop work order from the DoD. We had been actually hoping to launch this past summer, but we've been kind of in limbo for about 6 months now. Hopefully we'll be able to launch this in 2026. And our plan is to do a pilot implementation in 2 barbershops in Brooklyn. Given the initial pilot nature of this project, we have limited ambition in terms of the number of men we're going to reach, but our target enrollment is about 100 men ages 40 to 75 with no history of prostate cancer. And how do we envision that this is going to work in practice? Well, we hope that the barbers are going to engage their clients in a discussion about prostate cancer health. They'll discuss the pros of it. They'll discuss the potential cons of it. And then should the client decide that they want to proceed with screening, there will be a research nurse from our team on site who will obtain their informed consent, perform the actual point of care test. And then given the pilot nature of this project, we're going to also collect capillary blood from the finger stick to take back to our lab and measure using standard instrumentation. And it's ultimately that lab PSA test that we're going to report back to the clients at this particular stage. To better understand the acceptability and feasibility of the test and the setting, the participants will complete a brief questionnaire about things like demographics, socioeconomic status, perceptions of cancer risk, so on and so forth. And then the following day, the participants would receive their lab screening PSA test results, and staff from our team would coordinate follow-up care as needed. As I mentioned, this is a pilot study at this point. So our primary endpoints really revolve around the acceptability of the point of care test. Are men actually willing to get this test? And then the feasibility of implementing the test within the barbershop itself. As a secondary endpoint, we're also going to continue to look at the validity of the point of care test and evaluate the concordance between the point of care PSA test and the lab PSA test. So as part of this, we've been putting together lots of multimedia materials to use in both the training and as well as spreading the word about our initiative. So I just want to share one video for a few minutes here that we're using to hopefully motivate barbers to participate within our initiative.
What's up, people? My name is George, and I'm a licensed barber cutting out of Houston, Texas. I've been in the game for over 2 years now, and I love what I do. So, working in the shop, we see everyone from all walks of life. But how many of our clients' lives can we impact in just 20 to 30 minutes? Advocating for prostate screenings may not only catch prostate cancer early, but can also help diagnose other health conditions that your client may not have known about. In the United States, 1 out of 8 white men will be diagnosed with prostate cancer, but 1 of every 6 black men will develop prostate cancer, where they are twice as likely to die. These numbers show how important it is for men to get their prostate checked, especially black men. In fact, some men who have health issues with their prostate or have prostate cancer may not have symptoms. This means the earlier that men go to get their prostate checked, they will have more options for treatment. With that being said, we know why it's important to advocate for prostate screenings for all of your clients. Recommending your clients to have a conversation with their physician about a screening is the first step for them to start taking care of their prostate health. However, it's important to note that at a doctor's office, the patient has to consent to a screening or any other test that may need to be done. Basically, the doctor is going to conduct a prostate exam only if the patient consents to it. When your client goes to the doctor's office, they're informed of their rights and risks, so nothing will be done without their knowledge. So when your client goes to get their prostate screening, they will talk with their healthcare provider on what type of exam would be best. If your client is over the age of 50, it is usually recommended that they get their prostate exam. But if they're at higher risk for prostate cancer, they might have to get their exam earlier at the age of 45. In general, a prostate exam has 2 parts. A digital rectal exam, where the healthcare provider feels around the edges and the surface of the prostate gland to feel for anything that may seem abnormal. And a prostate-specific antigen blood test, or a PSA blood test, which basically measures the amount of protein that is made by the prostate. A normal PSA level is usually anywhere in between 0 to 4, but sometimes the levels can be lower or higher based on a man's age. If your PSA is high, it's sometimes not a big deal. More often than not, it's higher based on the size of the prostate, which means that more tests should probably be done to check that everything's A-okay. They might have to get a follow-up test with the urologist to ensure that everything is all right. Prostate screening can be a lot, and probably sensitive to talk about, but emphasizing the importance of early detection and checkups can push your clients to prioritize their health. I mean, they spend 20 to 30 minutes in your chair, so why not make the most out of that time to talk about their health?
Great. So that was a nice video that was put together by Cristo Ochoa, who's an alum of our MPH program. But I think I will stop there. I just want to thank all my colleagues here at Cornell and elsewhere, as well as our study participants, community stakeholders, and the funders that support all this work. And I'll stop and take some questions.
Thank you very much, Kevin, for a great overview and a great video with beautiful minimal music in the background. So we got carried away. I will open this very much for discussion, and whom can I give the floor? I see Dr. Stopsack opening his video. So perhaps, Conrad, you would like to ask a question?
Well, I actually just wanted to get us together by showing our faces because that does change the conversation. But yes, I do have questions too, of course. That was a fantastic talk. Thank you, Kevin. That was great. I'm curious about your perspective on what only came up in the video and you didn't advocate for otherwise, and that was a digital rectal exam, which isn't necessarily the most modern or the most appealing approach to screening for many people. I just wanted to get your thoughts on that.
Yeah, so I think it's what actually is more commonly. I think in the communities, many men are actually more familiar with the DRE than the PSA test. So we wanted to acknowledge it within the videos, but I agree that's really not the standard of practice these days. I think as a primary screening tool, there's very limited evidence that it's particularly beneficial. It's more of an adjunctive test. Perhaps it's more beneficial, but I think based on our conversations with community members, they didn't really want us to ignore it in the video because it was more of an aspect of prostate health that community members and men in the lay public were more familiar with.
Thank you. Can I ask you to take a liberty to ask a question about your basically your introduction? You said that it was highly controversial from the beginning, and I understand why that is. And one of the things that you mentioned was that I think in the PLCO trial, there were 30 to 50% missed aggressive tumors. So how has that changed, or is there change in that? Because that seems to me a very bad number.
So I think that I think that's probably higher at that point in time than it would be now. I think I didn't really touch on it today, but really PSA is just step one in an entire diagnostic cascade. And we've been adding more and more elements to this test to really help us identify men who are likely to have aggressive prostate cancer and reduce some of this overdiagnosis. So certainly the guidelines are moving towards recommending adjunctive serum tests, things like 4K score or prostate health index. Commonly, you would also hopefully get an MRI these days before proceeding to biopsy. MRI can also help with targeted biopsy and improve the specificity. So I think we've made considerable progress, and particularly since that's where the evidence stood in 2018. We made considerable progress in reducing sort of the false negative rates and then improving, really diagnosis of aggressive prostate cancer and trying to minimize diagnosis of some of these more indolent tumors. And certainly treatment paradigms have shifted too for these indolent tumors, where now no man that's diagnosed with a low-risk prostate cancer should really be getting surgery or radiation for that. They should be getting surveillance as their initial management strategy.
Yes, thank you. There's a number of questions in the chat. So Margaret Riordan, would you like to ask your question yourself?
Sure. I'm super curious. What is the all-in training time for the barbers that are interested in this course, and have there been any barriers to uptake based on those requirements?
So tough to say because we haven't done it yet. The plans are currently blocked. It should be 5 modules. So I think the plan is to meet on Monday evenings because most barbershops in Brooklyn are closed on Mondays and we don't want to take away from their work time. And they'll meet for about 60 to 90 minutes for each of these modules. So I guess that translates to about 5 to 7 hours worth of engagement with the team before this gets done in practice. We will be compensating barbers for their time, both in terms of the training as well as when they're actually when we have the testing available in their shops to actually do the screenings.
Thanks. I have a question from Oske Karanvil. Oske, would you like to ask the question? Yes, please go ahead. Yeah, I see you. But you probably would have to.
I think you're muted. Sorry.
Exactly.
Yeah.
Thank you very much for an excellent presentation. I was just curious, and I realized that this is a big question. As a simulation modeler, I've been working on multi-cancer early detection models, and particularly for, various types of cancers.
Yeah.
How do you think they're going to change, like how we perceive prostate cancer screening? How much do you think they will affect things for patients as well as for researchers? Thank you.
Yeah, so I think everything that I've said could be obsolete within the next decade if these multi-cancer early detection tests really take off. I think there's really not a great conceptualization of how to integrate them with existing screening tests and whether they're going to supplant them as the primary screening test or whether we're going to continue cancer screening as is. I think given that these are both blood-based tests, I think that it's likely that both of them will continue in conjunction with each other, at least for the foreseeable future. But how this shifts the downstream benefits and harms of prostate cancer screening, I think that's too early to tell at this point, but I think it's an exciting area.
Thank you. There's a question of Abdul Rashid. Rashid, please, would you want to ask the question yourself, Abdul? Or shall I read your question? Let me do that. I was curious about only one point of care setting for PSA screening. I wanted to learn if you have more than one community-based setting for the pilot phase.
So
and Abdul says he is in a library, so he cannot speak, so we understand.
No problem.
Yeah.
So I think we are eager to expand to a number of different settings if we can prove that this is an acceptable and feasible test. We purposely chose barbershops because I think there's an existing proof of concept there. So there's been lots of work, particularly in the hypertension and diabetes space, where there's seminal studies from Oakland, but more recently, our colleagues in NYU, just downtown from us, have been working in Brooklyn in hypertension screening. They've been doing diabetes screening, excuse me, within barbershops. So I think there's a proven concept that barbers can work with their clients and convey the importance of these health conditions and actually reach men that might otherwise not be regular patrons of the healthcare setting. Certainly, though, I think there's numerous other settings where this might be beneficial in terms of community screening events, things like churches or other organizations where groups of older men tend to meet in a routine basis.
Thank you very much. Well, we have, as you know, Kevin, a hard stop because of teaching going on, but anyone for a final question, or shall I take it up? Me too. Thank you very, very much, Dr. Kensler, for this presentation. We look forward and we hope you can start, that the DoD will change his mind and can start in 26 with your project. I have one other thing to say, namely next week's seminar, originally to be planned in person and online, by the way, as well, but in person will be only on Zoom because our speaker, Dr. Peter Kraft, is not able to come because of the government shutdown. He is the head of the NCI lab on cancer epidemiology and genetics, originally from here as well. So we look very much forward to Peter Kraft on Zoom to talk about genome-wide association studies, particularly in cancer. With that, I once again want to thank Kevin Kensler very, very much for his presentations, and I hope to see you all next week, same time, same place on Zoom. Thank you very much.
Thank you very much.
Kevin, thank you.